Jan, welcome to June. Fantastic month. There's some big events this month. It's Pride Month. We've also got Juneteenth on 6/19. Lots of stuff to celebrate. And of course, we've got another month of EMRAP.
So excited. And June is one of those special months where we have 5 Mondays. So there are going to be 5 weekly episodes coming out here in June. So even more content for you.
Fantastic. All right, Jan. Well, we do have to start with an intro case. You've got one for us. Let's dive in.
Yeah, this is one of those cases that kind of snuck up on me. You know, as Swami and I prepare these cases, we're often thinking about clinical pearls that we want to share with everybody. And this was one of those more emotional cases that I felt I really wanted to talk about with everybody. This was a case that happened to me just yesterday on shift where I was working, chugging along, regular shift, everything going okay, get a call from the social worker who says, hey, you know, Dr. Schoenberger, there's this family out in the lobby that they called me about. And these people are looking for their family member. This person's been missing for a couple days. I did a little research. I looked up the chart. I got the name, date of birth. I've confirmed that this is somebody who died in our ER 2 days ago. And I was wondering if you could come in and share this news with the family before I send them down to Decedent Affairs and the morgue. And, you know, of course, your first reaction is, you know, what? You know, how am I going to do this? A delayed death telling. Death telling is hard enough when you've seen a patient, you know, pass away and to have to sit down with the family. But to jump into this kind of a story without really knowing either party is really, really difficult. But, you know, the other question you ask yourself is who else is going to do this? I mean, this is something that needs to be done. It needs to be done compassionately. And so let me try to insert myself in here and see what I can do to help. That's what we really should be doing, even though we're in the midst of a busy shift with lots of patients in front of us. So step aside, take a look at the chart, read the story, confirm the events that happened best you can, even though you weren't there, and decide, okay, I'm going into death telling mode. Didn't see it coming, was not, you know, doing a resuscitation at the moment, but I got to go into death telling mode. So Swami, tell me about your approach to death telling and how you prepare yourself when you're about to do this critical task that we face ourselves with sometimes.
This is such an unusual one because we already don't have that in-depth personal connection with the patient when we're doing that death telling. We don't know the family. There are certain specialties where you have that relationship. So we're already going in impersonal under normal circumstances. Now we're even more removed from the case, which makes it really hard. So you really do have to kind of have a little bit of a reset, get in kind of that empathetic mode. And we often put that empathy on hold for periods of time during our shift, especially if we just resuscitated a patient or tried to resuscitate a patient. We have to put that empathy on hold. And now we have to re-engage it when we're talking to the family, when we're delivering that news. I think that I'm going to have to take a couple of deep breaths, really kind of get myself into the right space. You know, we talk about before resuscitation, make sure to empty your bladder. I'm going to do that here as well. I'm going to make sure to empty my bladder because I don't want any of my needs to step into the needs of the family. So I'm going to empty my bladder, take a minute. I'm not going to have time to eat something. If I'm hungry, that's also going to be a bad place to be in, but you got to do what you got to do. And then it's finding a quiet space to sit down with the patient. Once you're in that mode and you can talk to them, having the social worker there can be really helpful, but you don't have to have that at play. And then I think it is starting with the stuff that we always do. Introducing yourself, making it clear that you're the physician, asking them what they know already, because they might already know that their family member has passed, that is dead. And then you don't have to re-break the news necessarily, but you kind of need to know where they are before you start to deliver that news. So those are the first things that I'm going to do regardless of the circumstance. And then I'm going to try and communicate to them what happened, which might be really hard, especially since I wasn't there.
Yeah, I think this is particularly challenging when you weren't there. When you weren't there as part of the story, you don't know exactly how they were brought in. You don't know exactly what had happened. So reading the chart, trying to put yourself in that moment so that you can picture that resuscitation, be in the space where the providers would have been so that you can do your best to answer questions that they may have, because often there are questions that families have. So I did all those things. I kind of got myself in the space, look the part, you know, make sure that you look like a doctor when you walk into these rooms. You know, these are one of those, you know, people judge you in a moment. You're going to deliver something that they will remember for the rest of their lives. So you want to look like a doctor and someone that they would trust with the care of their family members. Do a pregame huddle with whoever's going in with you, if there is someone going in with you, so that you're both on the same page about where this is going to go, where this is going to end, where you can excuse yourself. Make sure your phone is off, that there aren't going to be any unusual interruptions in this particular case. Let your team know where you're going, what you're doing, and then enter this room. As I entered this room in this particular case, I could tell that they did not know. It was very clear to me that they were kind of chatting. It was two women. They were sort of chatting, and, you know, they just seemed to be like kind of everyday business, wondering what's going on. They thought it was a little, they were kind of looking around the room like, this is a little bit weird. We have a family room where we do these kind of talks, and they didn't know exactly why they were there, but they really didn't know what was coming. So I agree with you. I sat down, introduced myself, you know, how are you related? You know, let's just clarify who we're talking about, and then ask them what they know. I think that's a really good place to start, to get everybody on the same page about where we are. And so they relayed the events to me of a couple days ago where they had been at a family gathering, and, you know, this was a very happy time for their family, and they hadn't really heard from this person in the last day, which wasn't unusual in some ways. But then when they had checked in on them this particular day, they still weren't able to locate them. So they start calling around and getting nervous, and were finally referred to RER somewhere where this patient had gone. So that was kind of where they were. They really didn't know what else had happened. So, you know, then you have to catch them up to speed as to the fact that this person was brought to our trauma center after a bad trauma, and, you know, relay a little bit of the events without getting into too much detail. I think it's also important in these moments to give a warning shot, you know, to get them prepared that they're about to hear some tragic news. Before you say it and drop the bomb, give them an idea that something bad is coming, so they can kind of raise their level of you know, listening and focus to that moment. So I say, I'm sorry, but I have some really, you know, shocking news to share with you, you know, just to give them a minute to breathe. And then to say it in very plain language, to not beat around the bush, you know, not use anything that's unfamiliar to them. And all this time being very careful to use layperson language, not using medical jargon about what's happened, using terms that they may not be familiar with, but then to finally say that your family member died here. And then to just stop and like let it settle in. And that's exactly what happened here, as we've all experienced. The experience of acute human grief and suffering is what comes next usually. And that can be really awful for everyone in the room, obviously for the family members, but even for you as the physician as well. And to see the shock that was on their faces was, you know, those moments that that stick with you for a while, and to let them process. And I think in that moment, our job is to sit and to just let it happen. And our instinct always is to be like wanting to get up and leave, and we've got other things to do. But the most compassionate thing that we can do in these moments is to just sit and let them experience grief, and to just be there with them in this moment until they're ready to talk a little bit more, so that you can see what questions they have, and to again express your sympathies in whatever way that's comfortable for you. And so I want to see for you, Swami, if that resonates with you as to how you experience these events, and anything else that you think.
Yeah, I mean, there's so many good pearls you dropped in there just from the beginning of appearing to be a doctor. So this is the place where you actually want that stethoscope around your neck, if nothing else. Everybody knows stethoscope equals doctor or clinician, and that can be very helpful for patients just to frame things to start with. Body language is really important too. Don't have your arms folded in front of you. If you can sit, that's obviously preferred. Although I've been in situations where there was so much family in there actually wasn't a spot for me to sit down. And so you have to think about that as well. There is a little bit, it doesn't sound like your situation ran into this, but I've run into situations where there's a safety issue for me as well, and my team that's going into that room. So I also make sure that I'm close to the door, which I know sounds ridiculous, but I've run into this problem before. And so I make sure that I'm close to the door, that I have other people there with me, just because you just don't know what that situation is going to end up in. And then I like to, for lack of a better term, get to the end quickly. I don't like to take a lot of time to get there, because if they've been looking for their family member for 2 days, even if they haven't admitted it, they know something bad has likely happened. It might not be death, but they know something bad has happened. I don't want to take too much time getting there. So I will give a very, very cursory, here's what happened. I like the idea of prepping them with, and I have some terrible news. I have some shocking news, and then saying it. And you said how often we just want to kind of drop the bomb and then leave. You know, it's like, it's not a great idea. But the other thing that I see sometimes is people drop it and then they keep talking. And that's also not great. Just say it and then completely quiet and give them some time. And sometimes, I mean, that time feels like forever, even when it's only a couple of minutes. But then you're there to answer any other questions, to offer things like, do you want someone from the clergy? Is there some religious person that you would like to have in the room? We have a social worker. Those kind of things can be really helpful. You have to kind of know what your resources are, what your local resources are, and where those phone numbers are if you need to call someone in to help to support the family. But you have to kind of offer all that stuff. And that starts with the peace and quiet after giving that news. Jan, the other thing that kind of comes up pretty frequently, I'm sure you guys see it all the time, is you've taken care of the patient has died, and now a family member's calling and asking about that patient. My residents ask me this all the time. Do you give the news over the phone or not? So what's your standard? If someone says, I'm driving to the hospital now, I heard that my dad is there, or my mom is there, or my child is there, do you give them the news over the phone or do you not?
I think it depends. There is no guidebook to this one. This is one that's, kind of what is the right thing to do in the moment. Certainly if they're driving, I'm worried about them getting there safely. And if they're in the midst of transportation, it's better to just say, like, get here safely and then we'll talk, because delivering that kind of news while someone's behind the wheel is probably not a great thing. On the other hand, I've gotten, calls from people who live far away. It's going to take them time to fly and get there. And in that case, I would deliver news, because I think it's not kind to let someone suffer when you actually have information that they need. There can be timeliness to death for some religions and different cultures that needs to be dealt with. So I think that you should deliver the news safely, but not in the midst of a drive or something like that. So I think it does depend on the circumstances. It depends on the person who's calling. It depends on a lot of things. I don't think there isn't a rule that says you can't do that. And I think that's what often when people are learning how to do this, they're worried that they're breaking some rule by giving this news over the phone. I don't think that you are breaking any rules as long as you're being thoughtful about it and doing what you thought in the moment was the right thing, confirming identities the best you can, etc.
I kind of do the same thing. I have had a couple of situations where the patient is driving and they're calling me and they insist on kind of knowing. And I'm like, okay, can you pull over? And then let's have a conversation. I'm not going anywhere. I'm going to stay on the line. But most of the time, I'll just be like, you know what? I'm going to be here. Get here when you can, and we'll chat as soon as you get here. And people kind of accept that and move on. Right. But I agree with you. If they're at a distance, like, I'm in California, I'm hopping on a plane, I tell them at the time. I agree. Yeah. You just can't wait for the 8-10 hours until they're going to get to you.
Yeah, I think that's the right thing to do. Again, like I like to think of these things as how would I like myself to be treated? That's always a good gut check question, to know what the right thing to do is in a moment. And sometimes that's just the best test you have.
Jen, I'm sure there are lots of people out there who have done this far more times than they'd like to. And some people who are listening who haven't done it yet. Can you just kind of wrap up some of those big take-home things people can keep in their mind for the next time they go into it? Because even if you've done it 100 times, there's still a little bit more to learn.
Right. So I think the keys here, the few take-home points that I would leave you with is, first, know who you're going to go in there with. If anybody, look professional, turn off your phone and be prepared to be present. This is one of the most human experiences you'll have, and you want to be in the moment with these patients. And actually, I consider the family to be patients in those moments. They're about to go through an experience that can sometimes even result in, like you said, it can be the angry griever, it can be syncope, it can be physical reactions. So to take care of those people that you're going to be with, ask them what they know to get everyone on the same page. Try to do it in a very private space if at all possible. Give a warning shot. Give them an idea that they have bad news coming so that they can sort of mentally get into that space before you say it. Make what you say definitive. Get to the point quickly. Say that they died. Use layperson language with anything that you're describing or any questions that you're answering. When you drop the bomb, sit there. Just let it happen. Be close to the door. I have seen angry grievers. That is very, very true. There could be people that are blaming each other in that room for whatever happened that you can't anticipate. But let them have their reaction and let the news sink in, because at some point they will take a breath and they will think of things that they might want to ask you. And if possible, say something reassuring if they ask you about what happened. Try to make it as pleasant a death as you can in terms of characterizing it. There's no reason in this moment to make the family suffer further. So make sure that they know that this patient was in the best care possible, that the people around them cared about what happened to them, and there was expertise available. And if we could have saved them, we would have saved them, so that people feel like their loved one was brought to a place with expertise and good care, and that whatever happened to them that they weren't present for, that this person was in good hands. So reassure the family the best that you can. And if they have questions, try to answer them. Some people will offer their card or give contact information. Some people don't feel comfortable doing that, but sometimes people do have a last question that they really want answered that helps them process this grief. And I think that's a very human thing to do, but I understand that some people don't love doing it. And then finally, I want to leave everyone with the idea that after you walk out of a room doing something like this, you really do need to take a minute for yourself. Acknowledge that what you've just been through was hard for you too, and that while the instinct is to run back into your shift and just get going, that's not the right thing to do because you really aren't going to be present for that next patient. So take a moment for yourself to gather your thoughts, to get yourself back into a space, to get back into your care environment. And that does take whatever it means. I go into the bathroom. That's always my place of refuge because I know no one's going to bother me there. For some people, it's, going outside to take a deep breath with some fresh air. Whatever it is for you, find a way to sort of recompose yourself and allow yourself to process.
Such a tough case, especially when you weren't involved in the care. There's been a delay. But we have to step up and do it because nobody else is gonna. And I think we're pretty good as emergency clinicians of stepping into those roles and taking it on as it is our responsibility to do that. Now, Jen, we have a great lineup this week. But before we get there, I just want to put in a little plug for UC Max. Last month's UC Max that came out on May 15th, there was a great segment with Josh Russell and Mark Zeitzer reviewing a case of a 38-year-old man who presented to urgent care with left-sided chest pain after heavy lifting. He had signs of distress. The heart rate was elevated at 136. The patient was insistent that this was a muscle strain, but the medical team realized that this was obviously something much more severe, and the patient needed to be transferred to the emergency department for further evaluation. And they really get into this discussion of how do you have that conversation with the patient when they don't want to go to the emergency department? How do you decide whether they can safely go by their car versus calling 911 and transferring them by ambulance? And then how do you have the discussion with the patient that there are serious complications that we may be missing in the urgent care unless they go to the ED? How do you have that conversation with the patient to kind of frame it that you really need to get checked out somewhere else where they have more tools at their disposal to figure out exactly what's going on? It's a fantastic segment, something we run into all the time with patients. And so we need to know how to best handle that.
Absolutely. We have those conversations all the time about transferring for higher level of care and getting someone to another center and a family or a patient not wanting to go or not wanting to go via the mode of transportation that you want. So I think these are really relevant discussions.
Yeah, pop back over to UC Max. Check that out. I mean, honestly, you should be checking out UC Max every month, but at least check out this segment. Hopefully it's going to scratch an itch that you didn't know you had. You listen to the rest of the episode, pick up lots more tips on stuff that we deal with in the emergency department all the time. Let's get into the rest of the week. Our first segment is going to be the Crit Bits with Haney Malamut.